Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This presentation is titled, Is This the New Me? Pelvic, Prolapse, and Bladder Dysfunction. It is presented by one of our two Trinity Health IHA Medical Group Urogynecologist, Makela. Dr. Makela sees patients at our Schoolcraft campus location in Livonia. Take it away, Dr. Makela, and welcome.
Thanks, Allison. I want to thank everybody who's joined the meeting tonight. I appreciate you taking time out of your evening. And the goal tonight is that at the end of this, you should have a better understanding of pelvic prolapse, a better understanding of bladder dysfunction, and hopefully it gives you some confidence and hope, even if you're suffering with some of these issues. And if nothing else, you come away from this feeling more confident seeking treatment if you are having prolapse or bladder dysfunction. So let's start. Let's see. Oh, here we go. So what is a urogynecologist? Urogynecologist is a doctor that specializes in the diagnosis and treatment of women with pelvic prolapse and bladder dysfunction. There's basically two routes that doctors take, either gynecology or urology. Doctors enter into this area. I've been doing this for quite a long time. I spent my training at Wayne State University in the School of Medicine. After residency, I joined the faculty and spent about 15 years associated with the university, then moved out to Livonia, and I've been there over 12 years now. And increasingly I never set out to be a urogynecologist. I'll be honest with you. I always thought of myself as a benign gynecologist, but many of my patients, even 20 years ago, they were sometimes hesitant to go and see a specialist. And sometimes they wouldn't even go forward and get testing performed. And so I started doing the testing myself in the office, and just one thing led to another. One thing, urogynecology, the need for urogynecology has just been increasing at a rapid rate. There's a lot of studies that have been done trying to forecast and quantify how big the problem is. And I think people don't tend to agree necessarily with the studies, but they are in agreement that it's rapidly increasing. There's projections that there's not going to be enough urogynecologists because the supply is finite and it's growing, but the patient problem and the patient population is growing even faster. So what is pelvic organ prolapse? Basically, it's the movement or dropping of pelvic organs after damage or loss of the normal, I'm trying to move this, normal support for pelvic organs. Pelvic organs include uterus, vaginal canal, bladder, urethra, and in some cases, the intestine, even the rectum. There's two sources of support for pelvic organs. The prime support is connective tissue, and the secondary support is muscles. Loss of support occurs when connective tissue is either weakened or damaged or stretched or torn by, say, a pregnancy, maybe a surgery or motor vehicle accident in some rare cases. And then it allows pelvic organs to start moving into and through the vaginal canal. And one thing we know, we'll talk more about this when we get to bladder dysfunction, particularly when the bladder moves out of its normal position, it can really have a dramatic impact on how it functions. And simply getting the bladder back into a more normal position has a great impact in terms of improving function. It always has seemed to me that it should be harder than just moving it back to a normal position. But many times that's all it really takes. So when are you at risk for pelvic organ prolapse? Well, it's a long list of things that put you at risk. It's very, very common. It definitely increases as you age because your connective tissue changes as you age. Pregnancy probably leads the pack in terms of having an impact on do you have prolapse or not? The number of babies, certainly vaginal deliveries are associated. The size of the baby, and if the pushing stage of the pregnancy was long and involved forceps or vacuum, that also increases the incidence. So when there's a vaginal delivery and the baby is large and or there's long stage of pushing, we feel it causes damage to the connective tissue and the muscles and potentially even nerves. Genetics play a role. We know that there's a great study that came out 3 or 4 years ago showing that your incidence of or risk of prolapse increased if your mother had prolapse, if your maternal grandmother had prolapse, maternal aunts, and even female siblings. The more people in your family that had it, the more at risk you were. And a lot of that was the thinking that we know from old studies done more than a couple decades ago that there's a difference in connective tissue. Some people have connective tissue like an old rubber band. It stretches and it stays stretched or even breaks. And at the other end of the spectrum, people have connective tissue like a new rubber band. It stretches and goes back to its normal shape, and it does that indefinitely. We think that's partly genetics, and that may explain the finding of the study about people in your family having connective tissue and your increased risk. Smoking has been associated. However, stopping smoking doesn't really improve prolapse. There's a lot of theories, but nothing proven why smoking is an issue. Pelvic floor injury can certainly be a cause as well. And there's multiple reasons why pelvic floors become injured. What are the symptoms of pelvic organ prolapse? So these are all things that I hear from patients when they come into the office. Probably the number one thing is urinary incontinence, followed by fecal incontinence. Some people notice that before they develop incontinence that they had been a tampon user during their menstrual cycle, and now they're having a hard time placing a tampon or it won't stay in. And that's kind of confusing, but when I hear that, I know that that's a sign of prolapse. People begin to have pelvic pain, pelvic pressure, pain with intercourse. People will describe having a vaginal bulge that they notice. Sometimes there's bleeding because bladders and cervixes that are bulging come in contact with clothing, and they're just not made for that type of contact, and they get irritated and they bleed. Some people notice that they have a difficult time starting the urine. Their urine flow is slow, and or they don't feel empty when their urine flow stops. People are often describe difficult having bowel movements, or sometimes mistake prolapse for constipation. So as pelvic organ prolapse worsens, symptoms tend to worsen. The bulge or pressure may become a that is occurring throughout the day. It definitely worsens by the end of the day. People feel like they're sitting on a ball because now things are starting to, in some cases, protrude through the vaginal opening. People find that they have to splint, which is basically putting fingers in or around the vaginal canal and pushing on the vaginal wall to make it easier to have a bowel movement or even empty their bladder. People notice that they're having increased frequency of urination. That's usually because intestines or digestive tract and maybe uterus is pressing on the bladder. A lot of people notice they have lower back discomfort, particularly they wake up in the morning. They feel pretty good as they move through the day, and as they increase their activity, they notice that they have low back discomfort. A lot of the supporting structures, the ligaments and muscles, go to the back of the pelvis, and we think that is why you feel that way. The ligaments and muscles aren't doing their job, but they feel the tension from the prolapse, and you have referred pain into the back. The need to lift the bladder to urinate, and then again, pain with intercourse. These are all signs that the prolapse is worsening. Now, sometimes I see people that have milder prolapse, but they might have some symptoms on this list that we just talked about. So it varies from person to person. But if you look at large studies that break people into different categories of prolapse in terms of severity and the symptoms they have, this is kind of what you see, but everybody's unique. So what types of prolapse are there? There's basically 4 different types. There's anterior wall, posterior wall, apical prolapse and uterine prolapse. So anterior wall is the newer term we use. We used to use the term cystocele primarily, and that is basically the anterior wall of the vaginal canal is common with the bladder. The posterior wall is common with the rectocele, the rectum and bowel, and so, but that the newer term is posterior vaginal wall prolapse. Apical prolapse is also known as vaginal wall prolapse. That occurs after hysterectomy. So people have a hysterectomy and for a variety of reasons, but not prolapse, and then they notice over time that the top of the vaginal canal is dropping. And then if you still have a uterus, the uterus can drop into the vaginal canal and even through the vaginal canal. I'll show you some pictures. So this is a picture of normal anatomy. You see the uterus. The lower part of the uterus is the cervix, the bladder, the urethra, pubic bone, the vaginal canal, sigmoid colon, rectum, and then tailbone. And this shows everything in a normal position. So the sequence of pictures we'll go through next are highlight a particular body part that's moved out of its normal position. And typically, one thing that's not realistic about the pictures I'm about to show you is they show one body part that's moving, but in real life, usually it's more than one body part, but that's kind of a hard picture to draw or a hard picture to make sense of. So the pictures we'll show you now just show the bladder dropping into the vaginal canal. So if I back up, you see the bladder normal position and dropped. This would be a stage 2. Causes a lot of problems because we're asking urine to go uphill into the urethra. The urethra usually isn't straight anymore. It has more of a curve to it, so it slows the urine flow. It makes it harder to empty. And you definitely, you can have a pretty significant cystocele or anterior wall prolapse and not even be aware of it. When you reach the hymenal ring, then the innervation changes and you become very aware of it. So a rectocele or posterior wall prolapse is the rectum bulging into the vaginal canal. This is, you can see why some people mistake this for constipation, because in the normal setting, a bowel movement will move through the colon and directly into the rectum. When you're dealing with a rectocele, the stool tends to bypass the rectum and go into the rectocele pouch, and people can feel constipated. This is where sometimes people splint. They basically with fingers kind of push this pouch and redirect towards the rectum. Uterine prolapse, again, if we just look back to this picture right here, you see the uterus in a normal position. Now we see it in a very abnormal position. If this happens, you're very, very aware of it. This is stage 3. Most of the time I see patients at a stage 2 where the cervix is up a little bit higher. So how do you diagnose pelvic organ prolapse? I mean, we can be suspicious based on the patient's history, but you basically have to do a pelvic exam, and then we can tell what part is moving and to what extent it's moving. Many times, to get a better understanding of how prolapse is impacting things, we do a test called urodynamics. We basically take the bladder through an empty, fill, empty cycle, and then I have a pretty good idea what parts of bladder function are normal and what parts are not acting normally and are acting in an abnormal function and causing problems, such as leaking or not emptying. Often we'll do a cystoscopy to get a better idea of the inside structure of the bladder, and sometimes that takes us a completely different direction in terms of what we were thinking. So it's a very important test that we do. Imaging is often helpful. Sometimes we'll do a pelvic ultrasound in the office or in the ultrasound unit, or order a CAT scan or an MRI. Just depends on the individual patient. This isn't necessarily somebody, or we're not necessarily doing these exams on everybody, but sometimes there are some unique circumstances where we might be doing this type of imaging. So once you figure out that you have prolapse, what's next? There's actually a lot of options. Observation is very reasonable. I always tell my patients that have prolapse, you're ready to treat when you're ready to treat, and you always have the luxury of time. So just because you have diagnosis of prolapse doesn't mean you have to do anything necessarily. You can take your time. We usually give people a lot of resources to help them understand the various treatments. Sometimes they come back for a second visit and we talk through the options when they had a chance to learn a little bit more. Sometimes I always worry that I throw a lot of information at patients in the first visit. If they have a lot of questions, and sometimes it takes a little time to absorb all that information. And I always reassure patients, you're going to understand it. Today you've learned a lot. You're going to have more questions, and we try to give the patient resources or access to resources, so when they leave and they start learning more and expanding on what I've talked about, and maybe even doing some testing, they learn about the various options. For mild prolapse, pelvic floor exercises or physical therapy is an option. I had a patient in the office today that had early symptoms, didn't have all the symptoms that you would expect in a more symptomatic patient with prolapse. And sure enough, on exam, she had very mild prolapse, a stage 1. So she was very happy to discover she wasn't crazy, that there was actually a physical reason for some of her symptoms. And she walked out the door with a plan, and pelvic floor exercises was the plan for the next 2 to 3 months, with the understanding she could come back at any time, and certainly come back if she wasn't feeling pelvic floor exercises alone were helping her. Pessaries are, and we'll show you some pictures of pessaries. Pessaries are a very common option. I wouldn't say they're popular with every patient, but they are popular with many patients, and we do a lot of pessary fittings in our office. Pessaries literally go back to the time of the pyramids, although today we use silicone pessaries. There's descriptions of people using all kinds of objects, rags wrapped into a ball, soaked in wine, pieces of wood that were carved, stones. It's pretty wild, some of the stuff that they used. There's also surgical repair for pelvic prolapse. They fall into a couple different categories. There's apical suspensions that focus on supporting the very top of the vaginal canal. And there's those procedures that focus on the anterior and posterior vaginal wall prolapse. So here's an example of a pessary. The more common pessary used is a ring. The blue object here is actually a round ring that kind of folds and makes it easy to place in the vaginal canal. And see, it's in a perfect world, the pessary is supporting the uterus, the bladder, and the urethra. One of the challenges of pessaries, and we have different shapes. Probably the next most common shape we use has an increased diameter in this area to give the urethra some additional support. I always tell my patients, pessary is good at supporting the vaginal canal, the rectum, the bladder. Sometimes we struggle with giving the urethra adequate support so the bladder works normally. Gellhorn, a ring pessary, is easy to manage. Patients can manage that on their own in many cases. For more stubborn patients, or more, I shouldn't say stubborn, I should say more severe prolapse, that a ring pessary doesn't work, we'll sometimes move to a Gellhorn. But these are hard. Most people, they're hard to use. It's hard for patients to remove them. It's hard for patients to replace them. Usually we're using this to avoid surgery in an older patient. And it could even be a challenge for the doctor to remove and replace. So it's not something it's certainly not our first choice, but it's another option. And there's all kinds of other shapes. There's cubes, there's donuts. There's quite a few different options based on everybody's unique anatomy and unique prolapse. So pessaries, I would say probably 30 to 40% of the patients that we treat in our office with prolapse use a pessary. Sometimes patients will try a pessary and use it for an extended period of time, decades potentially. Sometimes patients will come back and decide that a pessary is not for them. And we talk about other options such as surgical repairs. So if we move into surgical repairs, really the focus on any type of surgical repair for prolapse is that it be minimally invasive. The reason for that is you have a faster recovery, you have a lot less pain, typically you have reduced blood loss. And when we can get you back to your normal functions quickly, postoperative complications drop. The most common procedures that I do are done robotically. And the reason for that is we can do very complex surgeries through very small incisions. And again, it goes to the last bullet point under minimally invasive. We can get you back to, we replace surgeries where we made big incisions with 5 basically 1/4 inch incisions, and patients often go home the day after surgery. On Tuesday of this week, I did 2 surgical repairs robotically. Both patients, when I saw them this morning, were feeling, they said, I feel sore, but I'm feeling really pretty good. And both were very motivated. They wanted to go home today. And by 3, 4 o'clock, the first patient went home around 1 o'clock, when we had comfort that her bladder was emptying efficiently, and the second patient went home like probably around 3 o'clock. That's pretty typical. There's also vaginal surgery that can be performed. One of the limitations of vaginal surgery is the repairs we would typically do that way don't have quite the success rates and long-term, particularly long-term success rates of the robotic procedures. So probably the most common procedure patients select, and it's based on 50 years of experience and 50 years of research. It's definitely the most, based on research, the most successful repair we have is called sacrocolpopexy. Literally, if you take the Greek or Latin root, sacro is the back of the pelvis right here, the sacrum. Colpo is a Greek or Latin for the vaginal canal. Pexy is to fix. So a graft, a very lightweight graft, goes on the outside of the vaginal canal and attaches to a ligament in the back of the pelvis. And it's the most effective treatment, surgical treatment we have for supporting the bladder, the vaginal canal, and the rectum. This part of the vaginal canal is in the pelvic floor. Sometimes we have to do different things in this area. So the pelvic floor can sometimes be hard to understand. It's just like the abdominal wall. There's an outside and there's an inside. Outside of the pelvic floor is easy to see. The inside is a little more challenging, but it kind of goes along a line, just kind of the same thickness roughly. But the urethra is predominantly in the pelvic floor. The rectal, the sphincter is in the lower part, last part of the bowel is in the pelvic floor, and the outer third to maybe 1/4 of the vaginal canal is in the pelvic floor. A lot of people, this procedure has, as of last year, was literally 50 years old. It's been refined and extensively tested. It does utilize mesh, but it's very, very different than transvaginal mesh kits, which came from Europe and were well-intentioned, but are no longer on the market. Transvaginal mesh kits were a very heavy mesh. They were placed in the vaginal wall, and the support came out laterally in the pelvis. So instead of going, this is much, the physics of this procedure are much, much better. And this is very lightweight and on the outside rather than in the vaginal canal. So what I find, patients who aren't attracted to, they've tried physical therapy, they're either tried a pessary or they're not interested in trying a pessary. And we start talking about surgical repairs. This is the most common procedure patients select. And this is done robotically. I trained doing this procedure open from a midline incision from about this point to about this point. So a very large incision. And now we do it through 5 small incisions, 8 millimeters, which is a little more than 1/4 of an inch. And that's what allows us, those small incisions allow us to get people out of the hospital and back to their normal functions very quickly. So let's shift gears. Let's talk about bladder dysfunction now. Pelvic organ prolapse is very common. I think bladder dysfunction is even more common. And again, people write and perform studies to figure out the incidence of bladder dysfunction. And there's a lot of disagreement over the numbers, but I think everybody disagrees it's very common. It tends to be increasing. Bladder dysfunction, probably the most common form of bladder dysfunction is incontinence, although frequency and urgency and getting up at night can be definitely fall into the category, but they're just probably not as common as leakage. We have far more patients that will come through the door and make an appointment and have concerns about urinary leakage than any other type of bladder dysfunction. The rate of or incidence of urinary leakage definitely increases as women age, although I see very young women that have incontinence. And it's important to understand that incontinence is not a normal thing at any age. Sometimes patients we think of things that are part of aging are things that we can't control, things we don't understand, things we can't diagnose, and that may have been true in the past. We didn't have great treatments. If you go back decades, several, 3-4 decades, we didn't have great treatments for some of these conditions. There's a lot of it we didn't understand. We didn't have the ability to test as easily as we do today. And definitely, I think urinary incontinence and bladder dysfunction has moved from a normal part of aging to something that we have significant advances in terms of being able to diagnose and treat. So what are the different types of urinary leakage? Definitely the most common thing I see in my office is stress incontinence, and that's the loss of urine that occurs with those activities that increase pressure in the abdominal cavity and cause pressure downward on the pelvic floor. Things like sneezing, coughing, laughing, exercise, even sometimes with more severe cases, standing and even walking. People will cough, sneeze, and they'll either release a small amount of urine or maybe a large amount of urine. It could happen infrequently, once a week, once a month, and then I see patients where it's happening multiple times throughout the day. Urgency incontinence is a form of overactive bladder. So we think of overactive bladder as a syndrome of urgency, getting that sense that you have to go and you have to go now. Frequency, urinating more than a greater number of times than you think you should, and it's reaching a point of interfering with their activities of daily living. By research, we define that as more than 7 times a day. Can include overactive bladder, can include nocturia, which is getting up 2 or more times at night. So we kind of break things into 2 different types. There's probably 6 or 7 different types, but the 2 things we see most frequently are stress incontinence, leaking with cough, sneeze, laugh, or lift, and then overactive bladder and urge incontinence. And we think what's the major issue in overactive bladder and urge incontinence is that the nerves that operate the bladder aren't working correctly. They're trying to make the bladder empty at times when it's certainly not convenient, or certainly when the patient doesn't initiate. The only time that part of the nervous system should be working is when you go to the bathroom after getting a sense that you need to urinate. You lock the door, you go through your normal routine, get your clothes out of the way, you sit down, and then you send a subconscious message that it's okay to go. Then the autonomic nervous system takes over. The autonomic nervous system controls all those things that we really don't think about: our heart rate, how fast our kidneys are working, how fast food is traveling through our GI tract, all those bodily functions that we don't control. Well, bladder emptying is one of those things. And with overactive bladder and urge incontinence, the system that empties the bladder is trying to work at times that we didn't initiate or give subconscious permission. Certainly there's issues where sometimes you wait and you wait and you wait and you wait a little too long, and then the bladder just empties. And that's a little different situation. This is overactive bladder can be, it's happening multiple times a day. And again, impacting your activities of daily living. So who's at risk? There's a big overlap between risk of bladder dysfunction and pelvic prolapse. Certainly pregnancy, vaginal delivery, history of surgery can increase urinary incontinence. It certainly increases as women age. Again, it has a lot to do with connective tissue and how strong the connective tissue. Vaginal delivery same thing with prolapse. Vaginal delivery can damage the connective tissue and the muscles and nerves that help support the bladder and operate the bladder. Again, the genetics play a role, just like for pelvic prolapse. In menopause, we know that when you stop making estrogen, that can have a profound impact on the how the bladder and the urethra and the urethral sphincter work. We previously did not think that adding back estrogen was an effective treatment. I would say for probably the last 5 years, there's been more of a focus on, with milder symptoms, adding not hormone replacement therapy, which is taking estrogen in some form that actually creates a measurable level of estrogen in your bloodstream, but using a local treatment like a topical gel or cream that reverses some of the menopausal changes in the vaginal canal and in the area of the bladder. There's a lot of interest in that area. Diuretics can sometimes just exacerbate. If you have a bladder that's not working well, a diuretic can just exacerbate the problem. Diuretics don't cause the problem, but they just exacerbate problems that already exist. So again, overactive, a little bit of a backtrack, but what are specific overactive bladder and urgency incontinence symptoms? Frequency, more than 8 voids in 24 hours. Although, I'll have patients that are used to voiding 4 to 5 times in a day, and now when they hit 8 or 9, it's very bothersome to them. So these are just general guidelines from studies done 20, 30 years ago, looking at the normal average number of times people void. Urgency is that sudden sense that you have to urinate. One moment you're fine, and the next moment you have to go. And it's very different than getting the sense that you have to go and waiting 5 or 10 minutes and then deciding to wait another 5 or 10 more minutes. And then you're in a situation where you really have to go. In this situation, you don't have that 5, 10 minutes. One moment you're fine, and the next moment you have a profound sense that you need to empty your bladder. And if you don't, you're going to feel like you're going to leak. Nocturia is waking up 2 or more times at night to urinate. So we think of 0 to 1 as being normal, 2 or more we think as being abnormal. And one thing we know about overactive bladder, the symptoms can be exceedingly complex. I've got patients that will come in and tell a story. This is a common story. I can be out all day, running errands, working, doing whatever. Then I come home and I put the key in the lock, and that seems like that sound is my trigger. And then I'm running down the hallway, trying to get to the bathroom, trying to get my clothes out of the way, and I'm leaking. And the question that patients ask is, well, how was I able to go through the bulk of my day or many hours of doing some activity like running errands, and then I get home and it's a whole different ballgame? And that's just one of the complexities of overactive bladder. We basically think that some of the sensory nerves that send signals about what the bladder is doing to the nervous system can cause a reflex at the level of the spinal cord. And then there's certainly issues that impact we know that the signal is going all the way up to the highest level in the brain. And then there's a reflex that causes issues. And it's probably more that what we call that supratentorial component of overactive bladder, where certain activities, the brain just understands it's not very convenient to go. But then when you're in a more familiar setting, it changes how the bladder reacts to the stimulus. And many times the stimulus is wrong. Typically when the bladder feels full, it is full. But with overactive bladder, you can feel that or get a sense that your bladder is full, but maybe the bladder is very much not full. Maybe it's only 20% full, not 80% full. And that's just a signal the sensory nerves are not doing their job. They're sending error message to the nervous system. It can be I get patients that come in, they do a bladder diary, and for 24 hours, and they record how often they go, how often they leak, how often they had urgency. They'll come in and they're going every hour. I've had patients come in going 20, 24 times a day, all night long. They're exhausted because they're really not getting good quality of sleep. The concern about leaking can cause limitation of activities and definitely have an impact on quality of life. I have talked to many patients who feel homebound because of their bladder symptoms. Again, and it's like everything I'm talking about tonight, overactive bladder and urgent continence is a very treatable condition. Stress incontinence, as I said earlier, it's basically activity that results in increases in the abdominal and pelvic cavity, and that increase in pressure results in pressure downward, typically on the pelvic floor and the bladder. So there's an immense amount of pressure that's generated when you sneeze or cough, and even laughing and exercising, and strain of exercising or lifting something heavy can cause a lot of pressure, and it impacts the bladder and can cause a leak. There's a great variance in terms of how often and how severe people leak. There's studies that have looked at how long does it take when somebody is leaking to actually seek medical care, and the average is 7.2 years. And I always tell patients, well, it kind of makes sense. I mean, if you're leaking once a month or once every other month, you're probably not going to make an appointment and go and talk to anybody about it. But when it's happening every day and you're soiling your clothes and you're out and you have an accident and you're worried that people can either smell urine or see that you've had an accident, it's pretty embarrassing. Many patients will come in, they've had some event that they've been suffering and living with the symptoms, but then there's some event that just is the proverbial straw that broke the camel's back, and now they've decided it's time. And again, like I said earlier, with pelvic organ prolapse, you're ready when you're ready, and not before. And I find that with many patients with bladder dysfunction and stress incontinence, there's something that happens typically that they just reach their point where they just don't want to live this way anymore, and then they come in and they seek help. And again, just like overactive bladder, stress incontinence can have an impact on limiting activities and definitely changing your quality of life. And again, if there's any message tonight, these are treatable conditions. So how do we diagnose? Again, history is a good start. It tells us, it kind of tells a story of what you're dealing with on your daily basis and how it's changed over time. Physical exam is very important because we can decide if the bladder is in a normal position or an abnormal position. We often will do a urine sample, and what we'll be checking for is chronic infection. A bladder diary, which I talked about earlier. I usually do a 1-day bladder diary. Some people will do a 2 or 3 day. I find I can typically get the information I need from 1 day, and it's not so cumbersome. Urodynamic testing I talked about that a little bit earlier, but that's basically a test we do in the office. It takes about 15 minutes, and you arrive with a full bladder. You sit on a special chair, you empty. The testing equipment records how much you urinate and how fast. We check to see what's left in the bladder, and then we fill your bladder with sterile water. You're telling us as you reach various levels of fullness. We have you cough, we try to recreate a leak, and then we have you empty. So we take your bladder through an empty, fill, empty cycle, and it gives us a pretty good idea of what part of your bladder function is normal and what part is abnormal. And that goes a long way to understanding what's really going on. I had a patient I did a UDT on today. And I really thought she had symptomatic prolapse until I discovered that when she came in, she emptied about 450 cc's and had another 300 inside her bladder, much greater bladder volume than most people could handle. And she had basically throughout her life for decades delayed going to the bathroom. She said her coworker that they sat in the same cubicle would go 4 times for every time, 1 time she went. So we decided surgery. I definitely didn't recommend surgery to her. She's going to over the next 3 months do more time voidings and just go every 2 or 3 hours at max, not waiting 5 or 6 hours, and try to reset her bladder, basically retrain the bladder to give her the sense to go at smaller amounts. She was actually getting in a position where her bladder was so full, she was having bladder spasms, and it was very uncomfortable. And that's what led to her coming in and us discovering about her immense bladder capacity, and we came up with a plan to treat it. Cystoscopy helps us understand what's going on inside the urethra and inside the bladder. Sometimes we'll find your chronic inflammation, mucosal abnormalities, stones, other evidence that there's bladder dysfunction, and it helps us understand what's going on and helps point us in the right direction in terms of a treatment. So what can we do about overactive bladder and urge incontinence? Pelvic floor exercises can definitely be helpful. Pelvic floor exercises came out in the early 90s, and it was meant to treat stress incontinence. And lo and behold, they found out it didn't do as good a job as they thought it would for stress incontinence. But women that had mixed incontinence, they had stress and urge. For some reason, pelvic floor exercises had a positive impact on urge incontinence. And that was not an intended finding, but nonetheless, it worked. It's been so successful in helping with overactive bladder that it's now, if you look at the American Urological Association treatment tree, it's one of the first things you do is start doing pelvic floor exercises every day. And there's not so much a focus on doing, now it seems silly, we would have in the 90s, We have people doing over 100 exercises today, and we focus more on low number but higher quality exercises. And I advise my patients, following the AUGS guidelines, American Urogynecologic Society, doing 2 to 3 sets of 10 a day. Definitely avoiding bladder irritants can make a big difference for some people, not all. But things like caffeine is a known bladder irritant, alcohol, spicy foods, citric acid containing foods, so lemon juice, lime juice, orange juice, grapefruit for some people is their trigger, and just limiting that can have a big impact. Sometimes when we take people through training, and that patient I just explained that had the big capacity is kind of an example of bladder retraining, but sometimes we find that the patient shows pretty normal bladder function during all of our testing, and they just try to, over a period of many weeks, train their bladder to wait longer. For some people that works, and some people that doesn't work. I had a patient several years ago that everything was normal. The urodynamic testing was normal. The cystoscopy was normal. Culture was normal. And so she figured out over a couple of days how long it took for her to get a sense that she had to go. And I think it was like 15 minutes. So the idea was that whatever that number was, every couple of days she would add 5 minutes and literally use a timer and try to get herself to wait additional period of time. I asked her to come back in 2 weeks, and mainly for a pep talk and to try to keep her on track. And she came in and was very happy to tell me she was up to 2 to 3 hours. So she went from every 15 minutes to 2 to 3 hours, and she was ecstatic because her bladder had controlled her life. That's at least the way she felt about it. And she had turned the tables. Now she was controlling her bladder. She had conquered it without medication, without surgery, without anything. Just her will, if you will, was basically what she used in her compliance with bladder retraining. And it was I wish you could have seen the look on her face in her description, because it was a very powerful moment in her life that she took control again and really improved her life. And the fact that she did it on her own was, I think, a very, very satisfying thing for her. We sometimes will use pelvic floor exercises, avoiding bladder irritants and even bladder retraining, and not get where we want to go. Patients will come back and say, well, I'm better, but it's still a problem. It's my bladder dysfunction, and my overactive bladder is still interfering with activities of daily living. I need to do something else. That's when we move on to something else like medication. Most insurance companies require us to do step therapy. So when we get to this point, we have to do medication before we can do some of the fancier treatments like bladder injections, like Botox, or even nerve stimulators. We look at the data out there that have looked at treatments and compared various treatments. Definitely nerve stimulators are the treatment that works the best based on studies. And it remains a very popular therapy for really severe cases or stubborn cases. Medication has been kind of a mainstay for many years. There's certain bladder medications that we don't use long-term, but fortunately there's some newer medications out there, such as Mirabegron and a new one called Gemtez. They tend to be very expensive. They're getting, especially Mybetriq is something you can take for a long period of time safely based on everything we know right now. Probably the biggest problem we have with medications are like some of the other things, so pelvic floor exercises, bladder irritants, bladder retraining. They give you small gains, but not really get you where you want to go. Sometimes medications just don't satisfy the patient in terms of the control they provide. They need something more. And that's where we move on to some of the other treatments. So stress incontinence, again, pelvic floor exercises still help some people. And again, it's more of a focus on quality and small numbers than a great number of exercises. Weight loss has been shown to help many patients improve urinary incontinence. In our group, we have a bariatric group that treats weight loss and does bariatric surgery. And we know from how they follow their patients, there's a direct correlation between stress incontinence and weight loss. Although we do see some people that lose significant amounts of their body weight and still it doesn't change their incontinence, but we do tend to see or think of it as a positive impact. Again, we can use pessary to support the bladder and the urethra, and then there's always surgical repair. So if we look at surgical repair, we basically have two options. Bladder slings, which have been extensively studied, that it tends to be an outpatient procedure when it's done by itself, and it has, based on studies, it has a very high success rate. Bulking has been around for a long time. Some of the products we had to perform bulking were not so good in the US. And over the last year or two, we've had some product that was bulking products that were being used exclusively in Europe. And now we have access to them in the US, and they're superior to what we had. There's studies that have been done in Europe that compared bladder slings to urethral bulking, and bladder sling is still the gold standard and the most successful treatment, but urethral bulking with newer products has improved dramatically. Right now I'm bulking in the hospital, but it is outpatient, and we hope to make it an office-based procedure in the future. We see high success rates. The beauty of bulking, it does not require mesh, it does not require incisions. The downside is that you might need more injections over time. The newer bulking agent is typically you do a bulking in the procedure, and at 3 months the patient follows up, and you may do a additional at that time. But the rate of the second injection is probably about 15% in studies, and we see 90%. Often 90%, and well, with sling, we probably see greater than 90% for sure. But for somebody who is not a surgical risk, somebody who might have pelvic organ prolapse, when you have pelvic organ prolapse, if we don't treat the prolapse and we just support the urethra, a sling doesn't work very well. What we're learning with bulking is that in some cases, if you have severe prolapse, you're still going to need to fix the prolapse, do something for the prolapse. But bulking is something that I think has a lot of options. You know, we think of it as the women that are younger that have had a baby and now they're leaking, but they plan on more babies. We typically have advised them not to do a sling if they were interested in a sling when other non-surgical procedures didn't work. Now we think of bulking might be just the ticket for that patient, the younger patient that wants to have babies, even though there's studies out there that suggest having a vaginal delivery with the sling in place doesn't damage the sling. There's a lot of studies that show that it does. And we think that bulking might be the option, a good option for those patients. And then patients who are done with childbirth, or maybe they don't want a mesh sling, or maybe they're not a great surgical candidate. You know, we just use sedation with bulking. So it's giving us more options. And again, it's an old thing that's been out there, an old treatment, but now it's something we're kind of excited about, that we have a better product. So here's a cartoon. This is the most common sling is a transobturator sling. So the bladder is right here, the urethra is here. This is meant to show that in the vaginal canals below, between the vaginal canal and urethra, a sling is providing some support for the urethra. Again, this won't support the bladder. The sling doesn't support the bladder, but it only supports the urethra. It is a very, very effective. This can be done with 3 incisions and 2/8 of an inch incisions on the perineum, and about 1.5 centimeter incision, 2 centimeter incision in the vaginal canal. There's an immense amount of, despite what some patients, I get a lot of patients that will come in and say, well, I had a sling and it doesn't work. And so I ask them a question. Do you leak if you cough, laugh, exercise, jump? And they say no, but they leak when they have urge. And so there's a lot of misunderstanding of slings, I believe. But it's not a patient's job to understand that a sling is not meant for overactive bladder or urge incontinence, but that's our job to educate patients. I don't think we've done a good job about that, but I do spend a lot of time educating patients what a sling will do and what a sling won't do. I had one of my old patients in today. I put a sling in her and did a support procedure, 12 years ago. And she was developing some overactive bladder symptoms. And I explained to her what the sling was meant to do and what it wasn't meant to do. And I think she actually had peace of mind. And we came up with some ideas to work on her overactive bladder. So she left happy. This is a picture, same picture that we've seen earlier tonight. You've got the bladder, you've got the urethra. The blue dots are where using a needle, we inject a water-based gel into 4 quadrants. So this is showing a cross section, so we're only seeing 2, but you do this at 12, 6, 3, and 9. And this is meant to show in this picture a cystoscope with a needle coming out that just goes underneath the mucosa or the skin lining of the urethra, and that's where we perform the injection. So you perform it in four areas, and it makes this is the area of the muscle sphincter that wraps around the urethra and acts as a valve, and it improves the function. Again, it's very, very interesting. Not a new treatment, but some of the agents we have are much, much better than they've ever been. So that is my talk tonight. I hope that you have a better understanding of prolapse. I hope you have a better understanding of why it happens. I hope that you understand it's treatable, and the same thing for incontinence. If you've learned tonight that these things are common, that there's reasons for them, that there's a multitude of treatments, and that you feel confident that you can seek treatment if you're having problems, then I'm happy and I've done my job. So Allison, I'll turn it over to you and we can answer some questions.
Okay, excellent. We have a lot of questions already. But if you have a question that you would like to ask, just enter it into the Q&A icon that's down at the bottom of your Zoom screen. And again, you can enter that anonymously if you'd like to. Just make sure you select that before you submit. All right, let's go. So are there specific exercises to strengthen the pelvic floor?
Definitely. I talked about it a little bit. Pelvic floor exercises are something we've advocated for a very long time. I trained at Hutzel Hospital, and we had a nationally known PhD in physical therapy who was very involved in our residency program and started from our very first year of residency. And so we kind of grew up in using physical therapy, and it hasn't really changed today, except the basic exercise is still the same. I think there's just a focus today on fewer, higher quality exercises. For some patients, we'll send them to biofeedback at a physical therapy unit where they'll use stimulation to help you if you're struggling to do a home-based program. Physical therapy, especially trained physical therapists, are available. There's a lot of things. I routinely, patients will come in, and I had a patient come in just yesterday and was talking, or Monday rather, and she had found something online. There's a lot of stuff online. A lot of that we don't see. A lot of that doesn't get studied. You know, most of what we're advocating for patients, it's gone through trials and studies, and some of these products aren't really being marketed to doctors or our professional organizations, but they're going direct to consumer. It's not to say those things don't work, but we just haven't tested them. So I always tell patients, I don't think it's going to hurt you. I'm just not sure it's going to help you. So, but we do know that pelvic floor exercises, which again, you can do in a home-based program, can be effective. And sometimes they add just a little bit, but you know, if we do a multitude of things or even small things that might move the needle a little bit and make you change your symptomatology to something that's much easier to live with, and then that's a win.
Is it a symptom if you're having urine leakage when you run or if you're bearing down?
Oh, definitely. Yeah, that's a form of stress incontinence. So like if you bear down, run, jump, cough, it's the same thing as cough, sneeze, laugh, lift. I mean, we have some patients just walk and they leak. Just those subtle, that activity, any activity, and it can vary greatly, that increases the pressure in the abdomen, pushes down to the pelvic floor, pushes down to the bladder, and then can cause leakage when the support for the bladder and urethra aren't what they should be.
Oh, okay. Is there any SI joint discomfort associated with this?
Joint discomfort?
Yes.
No, I don't believe so. If I understand the question, no, I don't think so.
Okay. Can this POP, POP, be mistaken for for the rectum meeting with the vagina, which bulges, not the bladder? So I'm assuming that means like a rectal prolapse. Can you mistake one for the other?
Not typically. I mean, a patient might not be sure what's bulging. They know something is bulging in the vaginal opening. And when we do an exam, we can typically tell you because we'll put a speculum in the vaginal canal and then we'll use half a speculum just to see, kind of push the posterior wall common with the rectum into a normal position and then have you bear down and we'll see if the bladder's moving and vice versa. So we can typically tell. That's the whole point of the pelvic exam, is figuring out, is it the bladder, is it the rectum, is it the uterus, the top of the vaginal canal, or is it a little bit of everything? And usually it's a little bit of everything. And there's always going to be a leading part, though. But I would make one distinction. When we rectal prolapse it can be confusing. A rectocele and rectal prolapse are two very different things. So a rectocele or posterior wall prolapse is where the rectum is bulging into the vaginal canal. But when doctors talk about rectal prolapse, they're talking about that becomes a colorectal issue. That's when the rectal mucosa is actually bulging out through the rectum, as opposed to part of the sigmoid colon bulging into the vaginal canal. So two very different things. But the difference is that you don't have anything bulging out of the vaginal canal, but it feels like something is coming out of the rectum. It's excess vaginal wall and lining, and it's pretty obvious because when you try to clean yourself after a bowel movement, you feel a big knob of tissue. It tends to be very sensitive. It tends to bleed, and it's very uncomfortable. So there's two different things we're talking about there. In the rectal prolapse talks about something very different than a rectocele.
Okay. And would you refer a patient to another specialist if you suspect that's the problem? The problem is with the rectum?
Oh, definitely. If there's rectal prolapse, we definitely educate the patient and we refer them to a colorectal surgeon.
Would you recommend this for someone in their 80s to separate the rectum from the vagina?
Separate the rectum from the vagina?
Yes, I'm assuming that would be like a rectal prolapse. Again, is that something you'd recommend for someone in their 80s or even the pelvic prolapse? Would you recommend this?
Well, it depends. There's 80-year-olds that are incredibly healthy and there's 80-year-olds that should stay out of the operating room. Rectal prolapse is typically a surgical repair. They can be done robotically by colorectal surgeons, or they can do some things transrectally. It's not to say I've got older patients that are in their late 80s and even their 90s, and they just don't want surgery. You can live with it. I won't say it's the most comfortable thing, but there's no easy answer to that question. You have to individualize and see how healthy you are, see how symptomatic you are, and seek the consultation of a colorectal surgeon for sure.
Okay. So really, pelvic prolapse or treating the rectal prolapse, it really is more than just the procedure. It's about the surgery as well, and that has to be consulted on an individual basis.
Right.
Okay.
So urogynecology would treat anything in the vaginal canal. So if the bladder is dropping in the vaginal canal, if the rectum is bulging up into the vaginal canal, the uterus is coming down, there's bladder dysfunction, that's something that I handle all the time. But if it's the actual rectal mucosa bulging out through the anus, that's a different story, and that's where the colorectal surgeon comes in.
Okay. Does a pessary work for someone who's had a hysterectomy?
It can. It definitely can. So a pessary can work with and without a hysterectomy.
And what is the success or length of success with this vaginal surgery with the mesh?
Well, the transvaginal mesh kits, which are no longer on the market, if that's what you're referring to, they had a higher failure rate for sure. The support was not, from a physics standpoint, it wasn't the best, and it was a very heavy mesh and it caused a lot of pain. That procedure isn't even available in the United States, and it hasn't been available for about 5-6 years. the procedure I showed you, the picture of the sacrocolpopexy, is a mesh-based procedure. It's been out for 50, this year it's going to be 51 years old. It's definitely stood the test of time. I think the benefits of it far outweigh the any risks of the procedure. And it's a very different risk profile than transvaginal mesh kits. And that's why transvaginal mesh kits had probably a shelf life of maybe 5 or 6 years, and then they started to fade away, and now they're no longer on the market.
We have another patient who had a hysterectomy 23 years ago and also had a bladder suspension using cadaver tissue. Is it possible that that could be failing at this point and having bladder leakage return?
Yeah, we used to use biologics as well as cadaver tissue, and that I think has fallen by the wayside. Sometimes there are certain doctors, it's becoming less and less common, will harvest some of the patient's own fascia and use that as a support. But some of the cadaveric and other products they're not as popular. There's been a lot of studies that they have a higher failure rate, and so when you look at polypropylene meshes, that's become the gold standard when you do a sling today.
Okay. This person has a full bladder every hour throughout the night for 5 straight hours. Is there a danger of electrolytes becoming imbalanced in the process of this taking place?
No, not in my mind. If your bladder is full, that I don't think that's, if I understand the question, I don't think that's going to impact your electrolytes.
Okay. And someone is asking, do you have cleansers or deodorants that you would recommend to patients when they come in to see you if they're having leakage issues?
A deodorant?
Yes, or a cleanser to cover odors.
Well, that's kind of a tough one. No, there isn't a product that we recommend. And that I've actually never had that question. That's an interesting question. There are some people, actually, I think it's an OB-GYN female OB-GYN that's advertising on TV about a product that like a cream, I think you can put anywhere for any bodily smell. And we've never advocated for that, never had any interest from patients on that. I suppose that particular product you could try. But I think there's been more of a focus on eliminating the leakage or reducing the leakage so that, some patients who leak constantly start to have a urine smell because you just can't shower every hour. So I think there's more of a focus on, instead of on covering it up, is treating the incontinence.
Okay. So this person said she wears a panty liner every day and has a little bit of leakage, but doesn't realize it when she's leaking. When I do feel the need to go to the bathroom to urinate, very little comes out most times. Should I be looked at?
Yeah, I think someone like that should be evaluated. Sometimes there's some basic tests like checking anatomy, doing a urine culture. That's in order in that situation.
Okay. Another person says that she goes at least 8 times a day and wears a poise pad every day. She is concerned about making it through a procedure. Is there anything else she can do?
She's concerned about leaking during a procedure.
No, making it through the procedure. She doesn't think she could make it through a procedure.
You mean, are you talking about a procedure like a bladder test?
No, let's see. Is it a cystoscopy?
No, it's pretty easy because we're
Okay.
not putting, we start the cystoscopy with an empty bladder and we put only enough water in, sterile water in to see what we need to see. And that patients, even with severe bladder dysfunction, typically, they don't have any problem doing that test, either the cystoscopy or the urodynamic test. That's not been a problem. Let me backtrack. With urodynamics, it's okay to leak during urodynamics when you think about it, because we kind of want you to leak during that particular test, because then we're monitoring pressures and nerve and muscle activity, and so for that particular test, you know, it's okay to leak because one is you're leaking water, and two, it's helping us understand why you're leaking. So for urodynamics, it's okay to leak, and it actually is helpful. With cystoscopy, it's typically not a problem.
Okay, it sounds like it may have been painful for her. Is that possible, or do you think something went wrong with that procedure?
The which procedure are we talking about?
The cystoscopy.
Because she's worried that she leaked during the procedure.
No, she said that it was painful.
Well, sometimes what we typically do is lidocaine gel, and most people, I'd say probably in this country, 90% of cystoscopies are done in the office. There's always patients that if it's uncomfortable, we stop, and then we reschedule the procedure. And we do it as an outpatient with sedation. So there's ways around that. If it's not meant, it may not be, it shouldn't be painful. And there's ways of dealing with that. But it's just a matter of, communicating with your doctor. And I get patients that come in all the time and they've had a cystoscopy and they're really not, they don't want to do another one in the office. So we just set up a time where we do it in the hospital in the cysto suite under some form of anesthesia.
Okay. There are lots of questions about bulking. Can you explain what bulking means?
Bulking is it's predominantly water, and it's like a water protein based gel, and it basically is helpful in women that have urinary basically stress incontinence, and it reduces leaking by bulking the area that let me back up a step. So normally the bladder empties into the urethra, and what prevents leaking out of the bladder is a donut shaped muscle that wraps around the urethra. As women and men get older, that muscle becomes less effective. Some of the connective tissue atrophies. So the sphincter muscle, the valve, if you will, becomes less effective. One of the treatments that we use is bulking that makes that the act of bulking makes that valve work better. And that's the goal. So with simple cystoscopy and injection of a gel, we can have the last 3 patients I've bulked have had come back and said they felt like they had a 90% reduction in leakage. And that's pretty powerful. You'll still get even a better result with a bladder sling. So, but bulking is another option.
Okay. This person says that her mother has been on different types of meds for years, but has not noticed a difference. She's recently been diagnosed with Alzheimer's and now wears Depends and uses them almost like diapers. She does drink a lot of water because she has dry mouth. Due to the Alzheimer's, she will not be able to do any exercises. What would our next step be?
Well, Alzheimer's is a tough one because part of continence, being continent of urine, meaning not leaking, is being aware of your surroundings, being aware of when your bladder is full, recognizing that, and then being able to act on that sensation and go to the bathroom and empty your bladder. So with severe Alzheimer's or dementia, some patients become unaware. Medication can help, but as I was saying earlier, it often doesn't work well enough. And that's where we move into other treatments, whether it's Botox or, you would need to start at that point. When a patient comes in and has been on medication and it's not working, that's a point where you have to stop, back up, start from scratch, do a history, do a good physical exam, potentially do some testing, make sure you understand what's really going on, and then move forward with a treatment. And if part of that treatment algorithm is medication, and you've tried several medications, then we don't go down that road. We try something different other than a medication. And there's a lot of options.
Overall, how would you say intercourse affects pelvic prolapse and bladder
Oh,
dysfunction?
well, definitely we see more and more people who are leaking with when they're sexually active. And that's become something in the last probably 4 or 5 years. Is probably a question we didn't ask enough or at all. And now it's something that we ask all the time. And maybe not be the question we lead with, because that can help patients decide if they have more severe prolapse, more severe bladder incontinence. It may be that because a pessary, for instance, would not be a good option for that patient, because you have to take a pessary out when you're sexually active, and it pushes a lot of people in the direction of a surgical repair. As far as prolapse goes, it's not going to hurt the prolapse. It may not be comfortable. I see two different types of patients with prolapse. Some are distinctly uncomfortable when they're sexually active, and that they're basically not any longer sexually active, and other people find it doesn't create a problem. So it's kind of, for some people it's a big problem to be sexually active with prolapse, and for some people it's not a problem at all.
Okay. Are there any downsides to getting a bladder sling at 40 years old with no planned pregnancies?
Well, there are studies that look at people who have midurethral bladder slings that have a pregnancy and a vaginal delivery and still remain continent. There's always been a great deal of concern that a patient will typically still advise patients who are planning more babies not to do a bladder sling, because we think the risk is high, that maybe it's not zero, but it's high enough that we would probably try other treatments, a pessary, urethral bulking, something other than a sling, and wait till you definitely with prolapse repair. Most doctors aren't going to want to do prolapse repair until people have had their completed childbearing, and it's kind of the same for a bladder sling.
Okay. This person had 4 vaginal deliveries. After she voids her bladder, she has to stand up, walk a few steps, then sit down and continue or finish voiding. So she's currently halfway through pelvic floor therapy and is seeing improvements, but it's not helping with the bladder issue. She's not
Yeah.
experiencing leakage, just trouble voiding.
I think that's a patient that needs evaluation. I think seeing a urogynecologist would be a good thing, because there's got to be something that explains that inability. Either through, there's a variety of things we see that we pick up in testing, from physical exam to urodynamics. I would say that I would recommend that person be evaluated.
This person had bladder sling surgery 18 years ago and now has further prolapsing with the rectum and uterus. She had PT and that helped, but is now having issues with her bladder not emptying all the way and sometimes leaks when she stands up after going to the bathroom.
Patient has, yeah. Well, I would say that based on that, I would say, again, evaluation, explore treatment options, and then, but I think the key in all this is is you need to be seen by somebody that is comfortable treating this, that has experience treating this, who can do an exam, do the necessary testing, and then give you options.
Okay. Is it possible for mild prolapse to resolve without intervention, or is intervention always necessary?
No, there are people that have mild prolapse or even severe prolapse that decide not to treat, and they just decide to live with it. It's possible. Many people decide that it's not compatible with their lifestyle. So patients always have an option, and observation is always an option. And I always tell patients that they're ready when they're ready to seek treatment, or they might come in and seek treatment and just try to have a better understanding of their options. But when they actually decide to do something, is up to them completely. I've got patients that decide they want to do something immediately. I've got people that take years to come back and decide to actually pursue a treatment. And then there's some patients that decide they're just going to live with it, and they might check in periodically just to see if to ask questions, but they continue down the path of not treating. So you don't really see, if you look at studies that follow patients with prolapse and what happens over time, the average patient slowly gets worse. You do see some patients that I think as some patients get older and they're menopausal for many years, the lack of estrogen can have an impact, and it seems to, I think it actually stops the prolapse from worsening, but that's not universal. It's a rare case, but so most of the time prolapse gets worse. Do you have to treat mild prolapse? No, you don't. You can live with it. It's a personal decision.
Okay. Are there drinks that can make the problem worse, like sparkling water, for instance, or super cold drinks? Are there things that you should avoid if you have bladder leakage or prolapse?
Known bladder irritants typically are products that have caffeine, alcohol. These are all things that when the metabolites of those drinks get into the bladder, they irritate the bladder and make you have to urinate more frequently. They don't really make prolapse worse, but then citric acids, spicy drinks, but that's mostly spicy food. So basically, citric acid, alcohol, spicy food, sometimes sweeteners, artificial sweeteners are irritants as well. But then I have patients that come in, they'll discover through trial and error something that's not on our list that is for them an irritant. And I always tell patients, just because you have overactive bladder doesn't mean you can't drink coffee. Just know that maybe you don't drink coffee before you drive up north for 2 hours, when you're not going to have access to a bathroom. It's just going in eyes wide open.
Do some procedures require the patient to have a hysterectomy to correct this?
The sacrocolpopexy?
Do any of the procedures require a hysterectomy?
Sacrocolpopexy classically is done with hysterectomy. And the reason for that is if you go back in the history of the procedure, in the early 70s, they did sacrocolpopexy with and without hysterectomy. They found out through trials that it works a lot better when the uterus is not there, and even when the cervix is not there. And one of the reasons is when the uterus is in place, it makes it very awkward or difficult to give the bladder adequate support. If with a bladder sling, if there is no uterine prolapse, no need to treat any type of prolapse, and it's just a pure stress incontinence, no, you don't need to do a hysterectomy for that. Overactive bladder treatments typically do not require a hysterectomy.
Okay. Can you talk about how your work differs from the Mona Lisa touch procedure?
Mona Lisa touch is a laser treatment, and it's really aimed primarily at it's for patients who can't take estrogen who have vaginal atrophy. There's been some interest that it might stabilize and improve stress incontinence. I don't think there's been good studies on that as of yet. What the treatment does is basically with laser, it creates multiple small incisions in the vaginal canal, which stimulates growth of new cells. And in fact, I saw a patient today that has used Mona Lisa, but she used it. The most common use is for patients who have vaginal dryness. They have a history of breast cancer, or for some other reason, they can't use any type of vaginal estrogen cream. And that's really what that procedure was intended for. Now, I know that there's a lot of studies going on. I certainly don't think it's mainstream. I don't view it as a viable treatment for treating prolapse, overactive bladder, urgent incontinence. I think there's some interest in some of these treatments to see what if it has an impact on mild stress incontinence, but I don't think there's any good studies on that. There's an interest, but I don't think there's studies that support that as a wide use option.
Okay, how would you treat chronic bladder infections?
In a menopausal patient, the number one thing that works is vaginal estrogen cream. In study after study, that's the most effective treatment. There's also interest in using prebiotic, probiotics, citric, I'm sorry, not cranberry extract, which acidifies the urine, D-mannose. Those are all things that we are currently using. In severe cases, sometimes we do put people on an antibiotic, but even if you take a daily antibiotic, that is not 100% effective in reducing recurrent urinary tract infections. So we see a lot of patients with recurrent urinary tract infections. It's predominantly a disease of menopausal women, but we do see some people that are premenopausal. But again, the treatment, the number one, the treatment that has been shown to be most effective is the continuous long-term use of vaginal estrogen cream, and usually the dosing is half a gram placed in the vaginal canal twice a week.
Okay. And what might cause those frequent infections? This person's asking if it is not being able to empty the bladder is causing those infections.
Well, we do know that women that don't empty their bladder and leave a pool of urine are at higher risk of bladder infections. That's really a small group of the women that have recurrent UTIs. We think what's going on is the menopausal changes after 3 to 5 years changes the lining of the urethra and the skin around the urethra, making it easier for bacteria that are naturally on the perineum, predominantly coming from the GI tract, to ascend into the attached to the skin around the urethra, ascend into the urethra and into the bladder and cause the infection. That's the current theory. And that can occur with or without prolapse. It's basically due to the menopausal skin changes that occur when you don't make estrogen.
This person has issues with frequency and urgency more than leakage. So would pelvic floor exercises be a good place to start? And how long would you suggest doing those before seeking help?
I think that would be an excellent thing to do. That's the American Urological Association, which writes the guidelines for overactive bladder. One of their first suggestions is to avoid bladder irritants. And number two, I think, or very high in the list, is doing pelvic floor exercises. If you're to do 2 to 3 sets of 10 exercises every day, and I think typically in 6 to 8 weeks, you're gonna know if it's made a difference. So I usually advise patients do exercises on a daily basis for 8 weeks, and if you're not seeing any improvement, then I want to see you back.
Okay. And does that count for leakage as well as the urgency and frequency?
Yeah, it can help for both.
Okay. Is stem cell therapy effective in regenerating connective tissue that supports pelvic organs?
Stem cell, did you say?
Yes.
There's a lot of interest in stem cell. There's a lot of research going on. I do think that at some point in time, I think stem cells are going to be used. There's still a question mark is, I think maybe surgery will be done in the future where we do something to, maybe it will replace mesh. I don't think you're going to be able to just inject stem cells into the vaginal area and it just moves things back into its normal position. I think you're going to have to do something to get body parts in normal position, but then maybe instead of using mesh, you use a stem cell therapy that helps regenerate connective tissue and provide support. But it's one thing to recreate some connective tissue, but you've got to get the body parts back in a normal position first.
Okay. Between a well-fitting pessary or having surgery, which is the most effective in correcting posterior vaginal wall prolapse?
I think if you looked at studies, both can be effective. I think you're probably going to have a higher part of the equation is patient preference. And I think there's definitely a preference on average. I think our office is pretty reflective. I would say probably 40% of our patients choose a pessary and about 60% of patients choose surgery. the one thing I'll say about a pessary is a pessary doesn't necessarily prevent a posterior wall prolapse from worsening, and it might be uncomfortable. I think surgery is probably a little more effective, but again, it depends on which surgery the patient and the doctor decide on. I think a sacrocolpopexy would probably be more effective in general than a pessary. I mean, I've always said to my patients, if you follow me through my office for a couple of weeks and you meet and you're there when I'm meeting with patients who have been using a pessary for a long period of time, and you meet patients who have had surgery recently or remotely, you can see pretty quickly there's a difference in the two patients. And even the medical assistant that works with me said to me one day, she said, I noticed that surgery patients are typically a lot happier than our pessary patients, because the pessary on paper sounds pretty easy, that you just put a pessary in and you take it out periodically and you clean it with soap and water and you put it back in. But that becomes very tedious to some patients, because as patients age, their tissue becomes more sensitive, and the pessary can cause erosions. Removing the pessary to clean it can be very uncomfortable. Patients don't look forward to those visits in some cases. And unfortunately, some of the patient education doesn't always tell the whole story. But I think if you followed me around in my office, you would see some of the patients that struggle. They are sticking to the therapy, but it's not always easy.
Okay. We just have a handful more questions. Do you mind staying on a couple more minutes?
Sure.
Okay. This person is able to empty their bladder by leaning to one side. Is that a symptom of prolapsed bladder?
That's usually a sign of obstruction. If the patient, often when the bladder drops, the urethra has increased resistance and maybe something like a kink. And patients are very inventive. They discover by leaning back, leaning forward, leaning to the side with their particular anatomy. That makes it easier to empty. So to me, the first thing I'm looking for is some type of obstruction. I want to know if the patient had a bladder sling placed at some point in time or had any other procedures done to the urethra. But if they've had no surgery, it usually tells me that the urethra is partially obstructed.
Okay. Do you ever use Botox treatments?
I have used Botox in the future, or in the past rather. I'll be honest, I have a bias against it. It's still a viable treatment. I've seen too many patients that start off and do quite well with it, and then at the 2-year mark, they tend to it tends to stop working. Where the typical regimen is we do a Botox injection every 6 months, and we'll see people do great for 6 months and then great for another 6 months, and it'll go on for a while. Then they'll call it 5 months, and then they'll call it 4 months. And then I had a patient 2 months after a treatment. Insurance companies will typically pay for 4 treatments a year, and I've seen too many people just see initial great results only to be followed by a lack of response, which is very frustrating to the patient in particular. I think we have other treatments that are actually better and work better long term, such as nerve stimulators.
Okay. This person experiences pain during pelvic exams, especially now that she's in menopause. Is there anything that can be done to make the exam less painful?
Well, probably the first thing is to make sure that your doctor or whoever's performing, your nurse practitioner, whoever's performing the exam, know that you find them uncomfortable. And then it should also lead into a discussion, are you a candidate for vaginal estrogen cream? And that would probably reduce, the most common reason for pain is there's atrophy, which is a normal response to long-standing menopause. When you're not making estrogen, the vaginal wall becomes less elastic and thinner, and that can often lead to a uncomfortable exam. So there are things you can do. You can use a smaller speculum, make sure your doctor understands that you find the exams uncomfortable, and then have a discussion, are you a good candidate for vaginal estrogen cream?
Okay, how often should a pessary be removed?
There's a wide variance in that. I've got patients that manage the pessaries themselves. They take them out every night, wash them with soap and water, put it back in the morning. I've got people that manage it themselves to take it out once a week, once every couple of weeks. We've got some patients that where we manage. Typically, when we manage, when we initially place the pessary, we have the patient back in 1 month, and we take it out, and or sometimes we don't. If they're doing really well, we just leave it in. There's some studies that came out of the pandemic where you can go as long as 6 months, as long as you're not having pain, bleeding, discharge, any signs of infection. So you can go up to 6 months. And for some people that works. It doesn't work for all patients. Sometimes we try that and we have to reduce the frequency back down to 3 months.
Are there any additional risks for somebody who has diabetes?
Well, if you have diabetes, diabetes is really more of a focus lately is on surgical risk. If the hemoglobin A1C is over 10 these days, surgeries get canceled. If you have a hemoglobin A1C of 10 and you present for surgery, anesthesiologist will often decline. There's some sense that if your A1C is 7, that may not be a good fit for it may impair healing, and it may not be a good fit for certain prolapse repair procedures. So we will often, patients that have a history of diabetes will look at their sugars, will look at their A1C in terms of counseling them about procedures that would be a good fit for them versus a bad fit. But even when the A1C, if the diabetes is not under good control and the A1C is elevated, I've seen patients in a very short period of time, a month or two, get much better control and correct their A1Cs and lower their risk.
Is there any risk of cancer by using the estrogen creams on a regular basis?
I have not seen that. It's a very different, estrogen cream is very different than hormone replacement therapy. A lot of the attitudes for hormone replacement therapy have changed a lot, but I've even had patients with breast cancer, estrogen receptor positive, who 5 years out, where their oncologist feels that using estrogen cream for prevention of recurrent UTIs, for example, is acceptable. They'll not say the same thing. They'll not ever say yes to hormone replacement therapy. But again, hormone replacement therapy is using some form of estrogen, trying to recreate a measurable level of estrogen in your bloodstream, where estrogen cream is not doing that. It's just simply trying to reverse some menopausal changes locally in the vaginal canal. So despite what it might say on a product insert, some of the product inserts don't follow what we know from research. And that's a company decision rather than something based on science. So I don't personally feel there is a cancer risk from vaginal estrogen cream.